So I wanted to start with clinician burnout syndrome itself. We're in the middle of what a colleague of mine quoted as the Great Resignation. More nurses are leaving the bedside than ever before. And 44% of nurses state at least one symptom of burnout. And one symptom is enough. It really is. In fact, it's one too much. Oh, and this thing's really touchy. So the turnover rate continues to increase. When I originally did this study, it was 16.8% per year. Now it's up to 18.7% in 2 years. So 2% is, again, 2% too much. And if you're thinking from the administrative side with cost effectiveness, it's $40,000 to $50,000 per nurse. That's a lot of money if you keep looking at it over time. Now you've got to also think about the travel nurses coming in and out and their onboarding and outboarding and all those pieces. But the issue is this results in increased risk for poor patient outcomes and increased risk for patient safety because there's less, there are less experienced nurses at the bedside than there ever was before. And believe me, I know I'm the one training the nurses coming out. Well, one of many, hundreds of many. All right. So, what does it mean in terms of documentation burden? Well, we use it to track data. And I always say that there's this kind of idea that there are a lot of places, organizations, anything, we're getting too drunk on the data. You know, like everybody wants the numbers, but really, do the numbers mean anything? I mean, that was hammered through my head for 4.5 years at UMass Boston. You know, data can help to, sorry, this is doing this. So nurses also spend about 35% documenting on their shifts, and Medicare and Medicaid obviously have identified burden as a problem. And again, we talked about regulations in the poll, like, you know, we can't get things changed, or there's too many clicks, or all these things, or they want all these great big screens. It's going to be a great idea. Yeah, well then they're just kicking the can down the road to us. So clinician burnout syndrome, I use Maslach burnout inventory, and Christine Maslach and Jackson define 3 major domains. Emotional exhaustion, it's that physical and emotional, like, I just can't do this anymore. That's really what it defines itself. Depersonalization, it's like treating a patient like an object, treating each other like objects. And diminished personal accomplishment, I call it the Eeyore syndrome. Why should I bother? And then it's a self-reported piece, but it's just as important. I think more so than ever before, especially amongst ourselves. I've got to stop pressing that button. Anyway, so I had a definition for this, and it might be a little different for the slides that are saved, but it's really the increased demand to document the EHR to track data. I had regulatory requirements in there, but with the influx of COVID and the changes, I felt that wasn't as relevant as it used to be. But it's still within the realm of the study itself. So Patricia Sensack defined 6 domains of documentation burden, and with her permission, I was able to use them in my study. So they're quality, usability, interoperability, self-report, reimbursement, regulatory. And they're all kind of like self-explanatory. So the purpose of the study basically is to determine the contributing factors. And does documentation burden link to clinician burnout syndrome? I have seen so many studies about clinician burnout syndrome and the interventions and how to save us and all this stuff. And I always had the question, well, if it's really worth it, don't we need to show that it's worth it, that it's really going to make a difference? And, but we have to show that there's a problem first. That was always kind of, again, drilled in my head when I went back for my PhD. So my aims were basically to examine the relationship of documentation burden and clinician burnout syndrome, and also to look at the usability of the electronic health record, because again, many of the studies talked about usability and how that was creating more documentation time demand and those pieces. And I don't know why it keeps doing that, because I'm not even touching it. Ooh. Okay, this is what we call technological fun. Anyway, so aims and hypothesis. Basically to describe the self-imposed effect, and I did a mixed method study, so it's quantitative and qualitative. The quantitative was using Maslach's burnout inventory. It was also to use, I'm just speeding a little bit because I know I've got a limited amount of time. Maslach's burnout inventory, there was a new documentation burden survey done by Dr. Jane Brown out of Australia, and I can't show it in here, but it will be in, I have permission to publish it, pretty much. And the other was, I wanted to hear the other side of the story, because numbers all tell you certain things. So, and I use Roy's adaptation model as well to kind of talk about adaptation and how that really helps. But just to speed little things along, I wanted to go over the gap in literature really quick. One of the major things here is that most of the burden that's in the published literature, there's a little more now. A couple of articles I found over the last year or two, thanks to COVID, that we actually had time to sit down and write something, that physicians, there was more about physicians' burden than nurses. I mean, come on, we always go, we're going to grin and bear it and just go with it. I'm serious. I really want to say, speak up. Because if you don't, I tell my students this, if you don't speak up, you're not going to get anywhere. And my favorite article was actually a set of trauma surgeons said that nurses should become their scribes. How does everybody feel about that? Yeah. Yeah, I livid is a nice word in a public setting. I have choice words that I cannot say right now. So anyway, I did the study at UMass Boston, and I had to, originally I was supposed to do it at Brigham and Women's Hospital, and then that was February 2020. Guess what happened in March of 2020? So we had to look inward at UMass Boston and the nurses that are in the RN to BSN post-licensure. And basically what I did was I did a convenience snowball sampling using email and a survey on Qualtrics survey, and I needed to get at least 85 participants. And I'll get into that because you know how surveys can go. And again, I used Maslach's burnout inventory, I used the system usability scale, and I did an interview guide. And I did a correlation for quantitative, and for qualitative, I did a code book. So I'm just going to go skip this a little bit. I got my ethical considerations, but I wanted to get to the results because of the time constraints. 85 nurses did respond to the survey. I could only use 69 because some of the survey was so long. So that was kind of a limitation here. And I had 11 participants in the qualitative scan, the qualitative strand. So as you can see, there was mostly women that responded, and the age was, you know, the average was between 21 and 34. So more so new grads, but also, again, this is around the time, it was literally at the height of COVID, and I imagine that everybody was overwhelmed and not wanting to answer stuff, which I totally understand. And in terms of demographics, most of them were in the ICU, but I heard some very interesting stories from the home care sector as well, because we really wanted to look this at a high level, not just inpatient nurses. I wanted to see what burden looked like across the board. Even if it was really general, at least it gave you a slight picture. So what I found was this, emotional exhaustion and burden of documentation, which basically was asking, like, do you feel like you double document and things of that nature, was statistically significant. And for emotional exhaustion and for depersonalization. So basically, they did feel like that they were being burnt out faster because of all the documentation they had to do. Same thing, the lack of a solid hospital leadership also showed some significant findings. The thing that I find really interesting, it's like the saying, you don't leave bad bosses, you don't leave bad jobs, you leave bad bosses. So, and that seems to be the saying these days. In terms of like looking at the burden of documentation subscale, which is, again, the double documentation, too much documentation, too little time demand, there was significant findings between time demand, the volume of the paperwork / EHR, and the documentation was confusing. And then in terms of usability, emotional exhaustion and usability were very strongly statistically significant. So usability is like the quick win here. But in terms of, I'm going to skip to the qualitative because of time. We looked at like the 6 concepts of documentation: time, demand, usability, interoperability, etc. And this is kind of like the concept map, which you can definitely view online later. I think the slides are posted on there. But what I loved was the narrative. It really kind of told a story. Like they, for documentation time demand, they're trying to do 16 different things. And at the height of COVID, I heard from several that were from the ICU saying that they had to handle iPads and Zoom in with families. And at the same time, they just rolled out the MyChart for Epic. And now families were calling the ICU and saying, did you look at these results yet? I've got them on my phone from my husband, my father. And the nurse is like, there's results?